Dear colleagues, we will return back to the second part of this lecture, anatomy of the spinal cord. We will go now to the lumbar spine. We will skip the dorsal spine in between the cervical and lumbar, and we will speak about the lumbosacral spine. The lumbar vertebra is classic. It is composed of a vertebral body, pedicle. Then we have two laminae that join together to form the spinous process, and the pedicle gives laterally to the transverse process, and after the pedicle there are superior articular facet and inferior articular facet, and in between there is part called pars interarticularis. Okay? And of course, here the spinal canal in which the thecal sac passes. If you look here, this is the pedicle, and below the pedicle, the intervertebral foramen forms. Okay, so the superior boundary of the pedicle is the superior boundary of the foramen is formed by the pedicle, while the posterior part is formed by the pars interarticularis as well as the facet joints. The space here, okay, just medial to the pedicle is called the lateral recess, okay, the lateral recess or the lateral neural recess. Let's speak about the ligaments that maintain the stability of the vertebral column. These ligaments are all through the spinal column, starting from the cervical downward to the sacral region. Anterior to the vertebral bodies, there is what is called anterior longitudinal ligament, and as you see, it is a wide sheet of ligaments. An equivalent but much narrower one seen posterior to the vertebral body is called the posterior longitudinal ligament. Okay? Between each transverse process, there is the intertransverse ligament. Between each spinal process and the other, there is a ligament called interspinous ligament. Between the tips of the spinous processes here, as you see, there is a ligament called supraspinous ligament. Okay, this is the supraspinous ligament. This is the interspinous ligament. Between each lamina and the lamina below, there is a ligament called ligamentum flavum. Okay, so we have anterior longitudinal, posterior longitudinal, intertransverse, ligamentum flavum, interspinous, and supraspinous ligaments. Again, we are looking into the vertebra from behind. This is the posterior longitudinal ligament. This is the anterior longitudinal ligament. This is the intertransverse. This is the interspinous. This is the supraspinous ligament. And in between the laminae and each other, there is here the ligamentum flavum. In MRI, there is a disc between the vertebral bodies. This is what is called disc space, and it is filled by the intervertebral discs. It is composed of bright central portion called nucleus pulposus and fibrous portion at the periphery called the annulus fibrosus. The bony interface which cover the disc is called the end plate of the vertebra. This is the inferior end plate and this is the superior end plate. For sake of stability, usually we divide the vertebral column into three columns. The anterior column is composed by anterior longitudinal ligament, anterior 2/3 of the vertebral bodies, and the anterior 2/3 of the disc. The middle column is composed of the posterior 1/3 of the vertebral body, posterior longitudinal ligament, and the posterior part of the annulus fibrosus or the disc. The posterior column is composed of the posterior neural arch, which are the pedicle, facet, lamina, spinous process, and of course the posterior ligaments. Which are the posterior ligaments? The interspinous, supraspinous, ligamenta flava, and intertransverse. When two of these three columns are disrupted during trauma, it will allow abnormal segmental motion. It means that this trauma result in instability or unstable vertebral fracture. Let us see what we can see in plain X-ray. This is the vertebral body, okay? You will see a teardrop-like structure in the midline. This is the spinous process. And these two structures are the transverse processes. And here there is an ovoid structure. Anevoid structure with thin sclerotic margin. These are the pedicles. Again, if you look to the vertebra, this is a posterior projection. This is the spinous process. As you see, this is the pedicle, well defined, superior articular facet, inferior articular facet, and this is the transverse process. In the anteroposterior view of the lumbar spine, let's applicate this. What is this? This is the spinous process. What are these well-defined sclerotic peripheral structures? These are the pedicles. Okay, you should see all the pedicles well-defined like this. As a rule, if you don't identify the pedicle well, this is a sign of metastasis, which is called pedicle sign. Okay. The other thing, as you see, the pedicles are diverging as we go downwards. Okay. If they are not diverging and that parallel, it means that we have spinal canal stenosis. These are one of the signs of spinal canal stenosis. And of course, you can see posterior to the pedicle, the facet joint. This is the facet joint. An important sign that you should know also that the longest transverse process is usually that of LV3. And as you see, there is a line here, which is the lateral border of the psoas muscle. If this border is lost, it means that we have posterior paraspinal pathology, psoas abscess or mass or something like this. Okay. This is a very nice pedicle, very nice pedicle, but here we don't see. Oh, this is what we call Winkling oval sign or pedicle sign. If you don't identify one of the pedicle, this means that it is affected by metastasis. Here also, we cannot identify the pedicle well. This is very important for you to notify. In all the spine, especially the lumbar and dorsal, go and make sure that you see all pedicles. I want to remind you regarding oval, there is another sign related to this very nice eyes, which is called oval sign, not Winkling sign. We can see hyperintensities in the anterior horn cells bilaterally, and this is a sign of metastasis, of spinal cord infarction, anterior spinal cord syndrome. In the lateral view, this is the vertebral body. Again, this is the pedicle, superior articular facet, inferior articular facet of the vertebra above. They articulate together to form the facet joint, and as you see, this is the vertebral foramen. It's bounded superiorly by the pedicle, posteriorly by the pars interarticularis and the facet joint, okay, and inferiorly by the pedicle again. We have superior portion and inferior portion of the vertebral foramen. It is keyhole-like structure, and the disc is related to the inferior portion, while the superior portion contains the exiting nerve root and vessels, as well as surrounding perineural fat. Okay? One of the important signs is to tell about the alignment. You should draw the 5 lines that you have seen in the cervical spine. There is anterior displacement or sliding of this vertebra on this vertebra. And we can measure it in quarters to tell mild, moderate, and severe, or grade 1, 2, 3, and 4, and sometimes 5, which is called spondylotosis, where the vertebra totally prolapse anterior to the lower vertebra. And here we should tell which type of spondylolisthesis is present. Is it lytic type, in which there is defect in the pars interarticularis, or degenerative, in which there is osteoarthrosis of the facet joint? Okay, this is the pars interarticularis, very nicely seen, and here it is interrupted. So this is a lytic spondylolisthesis. And here it is very important to do a projection, which is called the oblique view of the lumbar spine, which is very important to test 3 things. Number 1, the pars interarticularis, to tell if there is pars defect or not, to comment upon the facet joint, and to tell about the vertebral foramen. In the oblique view, we see a very nice demonstration, which is called the Scotty dog sign. The Scotty dog sign is composed of its ear, is the superior articular facet. Its nose is the tip of the transverse process. Its eye is the pedicle. Okay, so you can comment on the pedicle also here. Its neck is formed by the pars interarticularis. Here is the pars interarticularis, and its foot, anterior leg, is formed by the inferior articular facet. So look for this very nice Scotty dog, and it is very important to tell if we have interruption of its neck, to tell that we have pars interarticularis defect. Again, Scotty dog. And the MRI, of course, we all know that CT is much better for bone, MRI is much more better for soft tissues. As you see, vertebral bodies, the disc, the central portion is the nucleus pulposus, the peripheral portion is dark, it is the annulus fibrosus, and you can see the anterior longitudinal ligament, posterior longitudinal ligament, okay? And here we can see this is the thecal sac, this very thin line is the thecal sac posterior aspect, and this dark ligament is what? It is the ligamentum flavum, okay? And in between the spinous process, you can see the interspinous ligament, and this dark thread-like structure here is the supraspinous ligament. The thecal sac usually ends at SV1 or SV2. It's full of CSF, and the spinal cord usually ends at the lower border of LV1 or upper border of LV1. This is the tip of conus medullaris. And after that, there are nerve roots running all through the thecal sac here, called the coda equina nerve roots. The idea of coda equina nerve root to tell its number is that the nerve exits from the conus here, okay? And until it reaches the vertebra, it should leave the thecal sac at its level. It comes out of the thecal sac, then passes inside the lateral recess until it reaches the superior portion of the exit foramen to come out from it, above the level of the disc. We will explain this in the coming few slides. As I've told you, we look for T2 and T1, and again, this is the ligamentum flavum, and this is the interspinous ligament, supraspinous ligament, and this black line is the posterior border of the thecal sac. And in the lumbar spine, there is excessive amount of epidural fat, so you can see it surrounding the thecal sac. Here, it is bright in T2, bright in T1. This is the epidural, posterior epidural fat. This is axial diagram showing the idea of the enumerating or telling the number of the nerve root. Here, this is the disk space between LV4 and LV5. Okay? The nerve exiting from the foramen here, just above the level of the disc, is LV4. You remember our rule? The nerve in the foramen takes the number of the vertebra above. And here is the start of the lateral recess. Okay? The lateral recess contains another nerve taking the number of the vertebra below, it's LV5, and it is preparing himself to exit from the coming L5 foramen. You got the idea? So at each disc level, the nerve at the foramen is the nerve taking the number of the vertebra below. The nerve in the lateral recess takes the number of the vertebra below. Okay? And of course, the thecal sac contains the other nerve roots that are waiting for exiting from the thecal sac. And of course, here is the facet joint, the pars interarticularis, and two lamina. This is T1 and T2. As you see, the nerve in the foramen takes the number of the vertebra above. The nerve in the lateral recess, okay, the vertebra below. And as you see, this is the facet joint, this is the ligamentum flavum, and these are the two laminae spinous process. Again, the nerve in the lateral recess and the nerve in the exiting nerve root, okay, and the thecal sac is surrounded by perineural fat because this is T1, and very nice to demonstrate the bright signal of T1. And you should also look for the muscles surrounding the vertebral column. These are the two psoas muscle, is present in the lumbar region, and this is the posterior paraspinal muscles. Okay, you should assess them for collections, tears, tumors, and so on, hematomas, and so on. It's very important. Okay. As I've told you in the previous lecture, we don't look for the mid-sagittal only. We should go to the periphery to assess the nerve root, keyhole of the foramen, and as you see, the nerve is in the superior part of the foramen because it comes behind, just medial to the pedicle, which is the lateral recess, and turn to get out. And the inferior part of the foramen contains lymphatics, vessels, and all of them are surrounded by fat. And as a matter of experience, T1 is better than T2 to assess the foramina because the fat is bright in T1 and its obliteration means that we have abnormality in this foramen, either disc herniation, infiltrations, and so on. And of course, you can see the facet joints here. Okay, this is the facet joint. You can comment on the facet joint. Here we see the sacral spine. And as you see, the spinal thecal sac ends at SV2. In the CT, the same. We can see this is the level of the disc, the facet joints, pedicles, ligamentum flavum, thecal sac, and this is the peridural and perineural fats surrounding the exiting nerve roots and the thecal sac, and these are the paraspinal muscles. Again, in CT, facet joints, the disc, foramina, thecal sac, okay. We don't only look for the axial image in CT, we should go to see sagittal and coronal, and the same as we see in MRI. In CT, this is the disc, okay, disc, spinous process, this is a disc herniation, thecal sac in between, and the perineural fat. Okay. When the thecal sac, sorry, the ring, the complete ring is totally surrounded by bone here, we are at the level above or below the disc. So we can see the pedicle, the transverse process, two laminae, and spinous process. But at the level of the disc, the ring is not complete because we have the foramen here at the level of the facet joint. Okay, and as we go downward to the sacral spine, we can see the sacroiliac joints, okay, the two ala of the sacrum, and of course we will see the foramina of the sacrum, anterior and posterior foramina, like this. Okay, and as I've told you, don't look for the mid-sagittal structures only. You should go to the far lateral and parasagittal planes to look for the foramina, the pedicles, the facet, the pars interarticularis, and of course it is much more easier to tell that you have a pars defect in CT compared to the lateral view of X-ray and the lateral view and the sagittal views of MRI. CT is very specific to tell that we have pars interarticularis defect. Again, the foramen, the facet joint, and here the side of the pars interarticularis. You can easily see its interruption. Sometimes you can do 3D volume rendering. It's very nice to demonstrate the whole appearance like plain X-ray, and some surgeons nicely usually like this image because it is colored and it simulates the plain X-ray, and it can tell as if you are dealing with a jar or similar to what they will see during surgery. Let's go to the dorsal spine. The dorsal vertebra is similar to the lumbar vertebra, but because of the presence of ribs, there are facets for articulations with the ribs. Okay, we have a facet here with hyaline cartilage for the costovertebral articulation, and another facet at the tip of the transverse process for the costotransverse articulation. And these joints are liable to osteoarthrosis or inflammation or ankylosis in cases of ankylosing spondylitis, and you should comment on them during reporting because they may be the source of the pain, dorsal pain. Not every case of pain, back pain or dorsal pain is due to disc. We have a lot. One of them is the integrity of these synovial joints. In the plain X-ray, as you see, these are the ribs, and of course, don't forget, comment on the pedicles. They are all present here. Very nice. And you should also comment on the spinous process. In cases of trauma or in cases even of metastasis, you can miss one of these spinous processes. Okay, in the lateral view, vertebral body, intervertebral disc, the pedicle, okay, then the ribs overlap some of the data, and you can see some of the tips of the spinous processes here, okay. And of course, this is the intervertebral foramen. In the CT, this joint is what? Oh, this is the costovertebral. And this one is what? Costo-transverse articulation. And this a complete rank, okay, body, pedicle, transverse process, and two laminae. Okay, and this is the diagram. In CT, as I've told you, you should go in CT and MRI to the periphery to comment on the foramina like this and on the facet joints. Okay, facet joints and foramina. I want to tell you in the cervical region and in the dorsal region, the phenomena of lateral recess is not present here. Why? Because the nerves exit exactly at the site of the foramens, though they go transversely into the foramen. They don't go obliquely or vertically through the lateral recess then into the foramen. Okay? And here we can see the costovertebral articulations, and here the costovertebral articulation, and a lot of cases you can see pathology in these areas that can explain why the patient is suffering from back pain, not just disc. The ligaments are the same. We have ligamentum flavum, interspinous, anterior longitudinal, posterior longitudinal, intertransverse. The ligaments are the same, similar to the lumbar. In the MRI, vertebral body in between intervertebral discs, and this is the posterior boundary of the thecal sac. Posterior to it is the epidural fat, and this ligament is what? This is ligamentum flavum, and the spinous process in between them, the interspinous ligaments and the paraspinal muscles, as you see. And here, anterior longitudinal ligament, posterior longitudinal ligament. In the axial view, this is the thecal sac, this is the nerve, the spinal cord surrounded by CSF, and the nerves exit transversely at the level of the foramen and go outside. Okay, no need to pass through the lateral recess. So don't use the term lateral recess when describing a disc in the dorsal and cervical region, just foramina. And here very nicely, this is the costovertebral, costotransverse articulations, okay, the pedicles, laminae, and this is the ligamentum flavum. The T1 show the same, and here we can see the perithecal or epidural fat and the perineural fat surrounding the nerves. And of course, we have the posterior paraspinal muscles. This is the last part of our lecture. What are the vascular anatomy or the vascular supply of the spinal cord? The anterior two-thirds of the spinal cord is supplied by one anterior spinal artery and two posterior, while the posterior one-third is supplied by two posterior spinal arteries. The anterior spinal artery arises from the coalescence or the angle between the two vertebral arteries high above in the skull. Then the anterior spinal artery descend in a groove at the anterior aspect of the spinal cord, and because it is a long distance, it has a supplementary supply from the intercostal or lumbar arteries, which are called the radicular arteries. One of them is one famous called artery of Adam-Kevich, which arises near the lower thoracic region and supplies from 3 to 5 segments. We have watershed areas created between the anterior spinal artery and the posterior spinal arteries. The two posterior spinal arteries, similar to the anterior spinal artery, arises from the vertebral arteries high in the skull or the pica, and descends in two grooves at the posterior surface of the vertebral artery. And as you see, there are watershed areas between the anterior and posterior circulation. Also, the posterior spinal artery receives a segmental supply from the radicular arteries. Let us see. These are the two vertebral arteries, okay? The anterior spinal artery arises high above here and descends like this, and it receives supplementary arteries from the radicular arteries. And here, the two posterior spinal arteries, okay, and in cross section, one anterior spinal artery and two posterior spinal arteries. And as you see, they send the branches like this. The anterior spinal artery supplies most of the anterior whole and lateral whole, while the posterior spinal artery supplies the posterior column of the gray matter. And as I've told you, the spinal cord is not the same as the brain, it is the reverse. Gray matter is interior and white matter are exterior or at the periphery. Okay, and this is the spinal canal, okay, sorry, the CSF and the central canal of the spinal cord. So the anterior spinal artery supplies the anterior two-thirds of the spinal cord, including the lateral, both lateral corticospinal tracts and the ventral corticospinal tract, while the posterior spinal artery is the primary supply to the dorsal sensory column. And this cross-section nicely demonstrates the distribution of the blood supply, two posterior and one anterior spinal artery. Here, the artery of Adam-Kavach. Okay, usually this artery of Adam-Kavach arises at the lower thoracic or upper lumbar region. Okay, it goes through one of the foramina and make a hairpin curve like, then descends again backward. And this artery is very famous. Why? Sometimes if you have abdominal aortic aneurysm dissection or abdominal aortic aneurysm surgery, if this artery is torn or occluded, the patient presents by paraplegia. Okay, remember this artery of Adam-Kavach. How we can see it? Usually, as I've told you, sizable artery, it goes upward, forms a hairpin like this, and go back again and gives branches to make supplements to the anterior and posterior spinal arteries. Okay, you see hairpin curve because it arises either from the aorta directly or from one of the radicular arteries. This curved multiplanar CT angiography very nicely demonstrates the hairpin curve of artery of Adam-Kavach. You remember this sign? According to which artery is occluded, we have anterior spinal artery syndrome, posterior spinal artery syndrome, and other syndromes. I will tell you about them. When anterior artery, spinal artery is occluded, it results in infarction. It affects the anterior horn cells, and this is very nicely what? OLI sign, okay? OLI sign. It usually, we see it as a hyperintensity at the anterior part, and if we use diffusion, it can show restricted diffusion similar to the brain, and the clinical is very suggestive, acute, sudden paraplegia due to occlusion of the anterior spinal artery. Sometimes the hyperintensity is posterior if we have posterior spinal artery syndrome or occlusion, but usually the anterior spinal artery is more common than the posterior spinal artery stroke. Another more specialized or more localized type of infarction, which is called sulcal artery syndrome. You know, anterior spinal artery will send, if it is occluded here, it will make infarction here and here. But sometimes a branch from the anterior spinal artery which goes into this groove, it is called the sulcal artery. If it is occluded on one side, it may result in unilateral anterior horn cell fracture. This is called sulcal artery syndrome or sulcal artery syndrome. It results in unilateral cord infarction. I would like to thank you, and I hope that these demonstrations will help you in the coming lectures regarding the pathology to know how to easily diagnose what is the underlying. Thank you very much, and I wish you good luck in the coming lectures. Thank you.